very few points I have to mention at the pathology class. Most of the classes are basically from clinical aspect. So I will discuss these things under the clinical aspect only. So these three are mainly the broad headings of my lecture today. So I think all of you know what is jaundice. It's a clinical term. You all have at least some idea about the patient right now. This jaundice, or clinically it is known as icterus, is a part of day-to-day practice, routine examination, the initial general examination point. Like what are the other general examination points? You know, pallor, clubbing, jaundice, icterus, edema, cyanosis. So, what is icterus or jaundice? Usually is discoloration of either sclera or skin due to increased level of bilirubin within the blood. So, what is the normal level of bilirubin? What is the normal level of bilirubin in blood? Anyone? Tell me, what is the normal level of bilirubin in the blood? बोलो बोलो. Normal level of bilirubin. It is 0.3 to 1.3 milligram per dl. So arbitrarily, if it is more than 3 milligram per dl, but all hyperbilirubinemia cases are evident as icterus, or all they present us with jaundice. Are all the cases present us with jaundice? Yes or no? I think no. Only when the total bilirubin level is more than 2 milligram per dl, it will be clinically present as clinically, CL means clinically presents as jaundice. The whole term, in such cases when the level is more than 2 milligram dl and it is clinically present as jaundice, at the time of general examination we will see there will be Euler's discoloration of icterus, Euler's discoloration of sclera or skin. The level will be more than 2, and this condition is known as basically latent jaundice. Latent jaundice. Okay. So why we should bother about the hyperbilirubinemia? Why the bilirubin is so important to us? Because it's basically a toxic metabolite. Primarily it is handled by liver, and this, if the level of bilirubin is high, it will cause damage to any kind of the cell. Prominently it causes damage to brain, the neuron. Okay, and I will come later with this topic actually, but There is two type of bilirubin. One is conjugated, one is unconjugated. This unconjugated bilirubin has a high level of affinity with the blood-brain barrier because they can permeate through the lipid membrane. So they can easily cross the blood-brain barrier, and this unconjugated bilirubin can deposit within the neuron. It will called the condition actually called kernicterus. So, as it is a very toxic metabolite to each and every cell, body always try to handle bilirubin with a very great care. So, we should know at least some points about the metabolism of bilirubin. So, come to the next point, the metabolism of bilirubin. The bilirubin is handled by four phases of metabolism. One, the source of bilirubin. Of unconjugated bilirubin. Third, hepatic phase. So coming to the source of bilirubin, the main source of bilirubin, around 80% cases, hemoglobin. The whole term comes with the two words, one heme, one is globin. Globin is nothing but a protein. So if there is any degradation of RBC, the heme portion get converted into bilirubin itself, and the globin portion, I mean the amino acid, go into the amino acid pool of the body. Clear? Rest 20%. Rest 20% from non-heme enzyme like catalase, cytochrome, the myoglobin, and plus ineffective erythropoiesis. Clear? At the time of ineffective erythropoiesis, there will be huge destruction of abnormal erythroid lineage cells. So these metabolites of erythroid lineage cells produce heme itself, and they ultimately convert into bilirubin. Fine. So this heme within the blood gets converted into biliverdin. How? Under the effect of enzyme heme oxygenase. This is oxidation reduction reaction, and it needs NADPH, which gets converted into NADP plus H plus. So this is an oxidation reaction. Oh, এক minute. বলো. Okay. Okay. Bilirubin converted into initially biliverdin. In the next step, biliverdin reductase converts reductase converts biliverdin into unconjugated bilirubin. This unconjugated bilirubin is not soluble within the watery metabolite. I mean watery solute. It is not soluble in water. It is only soluble in lipid itself. So this unconjugated bilirubin cannot be handled in blood, or it cannot go alone into the liver. So they need a carrier. This carrier is nothing but albumin. এটুকু লিখেছো? Fine. In the next stage, the unconjugated bilirubin, albumin, and it produce bilirubin albumin conjugate. This bilirubin albumin conjugate go within the liver, and in the sinusoids albumin gets detached. So, and ultimately it permeates. Suppose these are sinusoidal lining. Within the sinusoidal lining, it permeates into the space of Disse. Within the space of Disse. And here comes a role of another conjugation, which is known as glutathione. So this unconjugated bilirubin transferred into hepatocyte with the help of glutathione ACE transferase into hepatocyte. So within the hepatocyte, this unconjugated bilirubin binds with glucuronic acid. তাহলে এতদূর পর্যন্ত কি হলো? Unconjugated bilirubin within the blood binds with albumin. It acts as a carrier protein, and those whole unconjugated bilirubin albumin complex go into sinusoids, and it permeates through the sinusoids. At the time of permeation, albumin gets detached from the complex. Within the sinusoids, unconjugated bilirubin transferred it into the hepatocyte with the help of glutathione ACE transferase, and within the hepatocyte, here takes place the actual conjugation of bilirubin with the glucuronic acid. ঠিক আছে, এটুকু বুঝেছো? So within the hepatocytes, bilirubin binds with glucuronic acid. With the help of UDP glucuronyl transferase. Hence, it converted into conjugated mono or bi glucuronate. Mono or bi bilirubin glucuronate. Conjugated mono or bi bilirubin glucuronate. Within the hepatocyte, they get converted into a conjugated bilirubin, basically. This conjugated bilirubin, the help of কিছু বলছো mono or by UDP, with the help of UDP glucuronil transferase, UDP glucuronil transferase, it binds with the glucuronic acid and converted into mono or bi-glucuronide. And with the help of active energy dependent process, they actively secreted within bile canaliculi. Conjugated bilirubin secreted within the bile canaliculi. So this whole process going into the hepatocytes itself. So starting from the albumin bilirubin complex uptake to secretion of conjugated bilirubin canaliculi within the bile canaliculi, the whole process taking part within the liver. So this is known as hepatic phase. So last phase is intestinal phase. Intestinal phase. Into hepatic duct, through the common bile duct, they go ultimately into the small intestine, and it passes through the small intestine up to large intestine, and within the large intestine it is known as stercobilin. Within the large intestine, this bilirubin converted into stercobilin, and under the effect of different microbial enzyme stercobilin bilinogen. Ki? I am not audible. Hello. কি হচ্ছে অভিমন্যু কি হচ্ছে শুনতে পাচ্ছে না বলছে হ্যালো 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 am I audible? Okay. So within the colon it gets converted into urobilinogen. There are three fate of urobilinogen. One part gets absorbed within the colon itself and it undergo enterocolonic or enterohepatic circulation. Okay. So they again reabsorbed in the small intestine and go into the liver. Again within the liver they get resecreted within the bile canaliculi, and this the cyclic process is going on and on and on. It is known as enterohepatic cycle. Second part, this urobilinogen a small part go into urine, and the normal yellowish color of urine usually comes due to the presence of urobilinogen. And third, this urobilinogen gets converted into urobilin and excreted within the stool. Urobilin excreted in stool. That's all about the metabolism of bilirubin. So starting from degradation of heme, hemoglobin, the heme converted into bilirubin. Bilirubin initially is unconjugated bilirubin form. This unconjugated bilirubin form gets converted into the conjugated bilirubin form within the hepatocytes. This conjugated bilirubin within the hepatocytes secreted into the bile canaliculi and comes within the small intestine. Here, from the small intestine, it go into the large intestine as a neurobilinogen. Usually, it was the starcobilin initially, and under the effect of microbial enzyme degradation, it gets converted into urobilinogen. Urobilinogen, there is 3 fate of urobilinogen. Some portion of urobilinogen undergo enterohepatic circulation and resecreted within the bile, and this cycle goes on. This is the major portion, around 45% portion. Some part go into the stool as a starcobilin, they get excreted, and some part go into the urine, and the normal yellowish color of urine is due to the presence of urobilinogen. So, urobilinogen itself is water soluble. So, what is the major difference between conjugated and unconjugated bilirubinemia? So, there are 2 types of bilirubin. You have seen here, one is unconjugated. Tell me. জোরে আমি কিছু শুনতে পাচ্ছি না। Urobilin. Starcobilin present usually within the small intestine. Under the effect of enzyme of microbes in the large intestine, it gets into the urobilinogen. Okay. So the points of differentiating points of versus the normal level initially. What is the normal level of conjugated bilirubin? Not more than 25%. Not more than 25%. So majority is conjugated bilirubin because this is the main form. Okay. Next point. Water solubility. Unconjugated bilirubin is not water soluble, but conjugated bilirubin is always water soluble. Third point, lipid solubility. Unconjugated bilirubin is, yes, it is lipid soluble. This is the reason why the unconjugated bilirubin actually carried by the albumin, unconjugated bilirubin albumin complex go or it permeates within the blood-brain barrier. It goes through the blood-brain barrier and deposited within the neuron, and this condition is known as kernicterus. Lipid solubility. Fourth, number 4, Van reaction is a biochemical reaction by which we can estimate the blood level of or any urine level or any kind level of unconjugated and conjugated bilirubin. Usually with the help of Vandenberg reaction, the conjugated bilirubin can be directly measured. But unconjugated bilirubin measurement is indirect, means there will be two type of measurement, total bilirubin level and conjugated bilirubin. So total minus conjugated bilirubin level is nothing but unconjugated bilirubin level. Okay, and number 5 এখানে লিখি, number 5 যেটা বারবার বলছি, is always caused by conjugated bilirubin, but it is not caused by unconjugated bilirubin. It is not caused by conjugated bilirubin. ঠিক আছে, বুঝলে? So what are the difference between conjugated and unconjugated? The normal level of conjugated bilirubin is always less than 25% of total bilirubin, but unconjugated bilirubin is majority of total bilirubin. Okay, usually 80%, 70 to 80%. Conjugated bilirubin is always water soluble, but unconjugated bilirubin is lipid soluble. With the help of Van der Waals reaction, the conjugated bilirubin can be directly measured, but unconjugated bilirubin cannot be measured directly. It is an indirect process. Okay, and carnipteras is always formed by unconjugated bilirubin. So, what are the causes of unconjugated bilirubinemia? Enumerate the causes of unconjugated bilirubinemia. মুছে দিচ্ছি, এতদূর পর্যন্ত বুঝেছো? কারো ডাউট আছে এতদূর পর্যন্ত? এবার প্রপার ক্লিনিক্সে ঢুকবো। কারো ডাউট আছে এতদূর পর্যন্ত? Anyone, do you have any kind of doubt? Please clear here. Okay, fine. What are the causes of unconjugated bilirubinemia? Or your question will be as such: enumerate the causes can be broadly divided into 3 headings: increase, destruction, or increase production of what? কি হতে হবে? আনকনজুগেটেড বিলিরুবিন কে ব্লাডে বাড়তে গেলে কি করতে হবে? প্রোডাকশন বাড়তে হবে। প্রোডাকশন অফ হোয়াট? দ্য মেইন সোর্স অফ আনকনজুগেটেড বিলিরুবিন, হিম। Production of heme. Second, decrease hepatic uptake. তাহলেই না আনকনজুগেটেড লেভেল উইদিন দ্য ব্লাড বাড়বে, তাই তো? Unless and until if the hepatocytes are not working, the unconjugated level within the blood automatically rises. And the third effect is decrease conjugation of what? Unconjugated bilirubin. So concept e বুঝতে পারলে? There are 3 concepts. One, increase production. Second, decrease hepatic uptake. And third, decrease conjugation of unconjugated bilirubin. So, what are the causes of দুটো বলো? Increase production বলো, তোমরা বলো। জুড়ে ineffective erythropoiesis. Excellent. Ineffective erythropoiesis. But the most important condition, আমরা সবাই পাই, what? Hemolytic anemia. What kind of hemolytic anemia? Intravascular, extravascular? Intravascular. Both. Basically both. Majority, the causes are intravascular hemolytic anemia, but also in cases of extravascular hemolytic anemia, there will be increased destruction of heme. So, hemolytic second, what are the causes of the liver is not causing any kind of metabolite to enter itself within the hepatocytes. The hepatocytes are not allowing the metabolite within to enter within itself. Okay, one, of course. Why? There will be periportal fibrosis. So they are not going into or they are not permeating through the sinusoids itself. Second, sepsis. Third, pregnancy. And fourth, of course, cirrhosis. And what are the causes of decreased conjugation of unconjugated bilirubin? Is very, very important for your syllabus. There are two hereditary conditions. Two hereditary conditions. So first, cricketer and second, Gilbert syndrome. Okay. Two. লিখলে মুছে দেব? লেখো। Two acquired condition. One, drug. How? There are some important drugs are there like sulfonamide, salicylate, sulfonamide. Just এই দুটোর নাম মনে রেখো। 23 drugs are there, but these two are very important. These two drugs basically causes displacement of albumin from albumin unconjugated bilirubin complex. They causing displacement of albumin. Albumin জায়গাটাকে সরিয়ে দিয়ে they causes displacement of albumin. So the albumin cannot carry the unconjugated bilirubin into hepatocyte. So the first cause is drug and second and there is another condition apart from these two hereditary and acquired condition. There is another very important for you is neonatal jaundice. Neonatal jaundice. পরে হচ্ছে, আমি কোনো টপিকের কিছুতেই যাচ্ছিই না, জাস্ট enumerate the causes. Neonatal jaundice. So clinically, what are the features of unconjugated hyperbilirubinemia? Clinically, what are the features of unconjugated hyperbilirubinemia? কি করে দেখো তোমরা জন্ডিসের কোনো পেশেন্ট যখন আসে তখন how can you classify that could be a conjugated hyperbilirubinemia, that could be an unconjugated hyperbilirubinemia, etc, etc. Yes, of course there will be icterus. So point number 1 will be icterus. লিখেছো এতদূর পর্যন্ত? Icterus. Second, dark color of urine. Why? There is huge amount of urobilinogen within the urine. Okay. Third, abnormal LFT. Within the abnormal LFT, alkaline phosphatase, gamma glucoryl transferase GT, both the alkaline and gamma glucoryl transferase level, these two enzyme level will be high. Okay, and if it is a case of infective erythropoiesis or extracellular or intravascular or extravascular hemolysis, there will be evidence of extra medullary hematopoiesis. Extramedullary hematopoiesis. Why? Exactly. In case of like thalassemia, sickle cell anemia, etc., etc., in huge cases there will be evidence of extramedullary hematopoiesis. Fine. These are the main clinical features of unconjugated bilirubinemia. Now coming into the second part, the conjugated hyperbilirubinemia. So what are the causes of conjugated hyperbilirubinemia? Either there will be intrahepatic cause or extrahepatic cause. So if it is an intrahepatic cause, there will be some defect either in the canaliculi or there might be some defect at the time of secretion, active secretion of hyperconjugated bilirubin within the canaliculi. Any of either of two condition, either there might be any abnormality in canaliculi, biliary canaliculi, or there will be abnormality in secretion of conjugated bilirubin within the canaliculi, any either of two, or there might be an extrahepatic cause. Basically an obstruction of hepatic duct or common bile duct. So if coming to the first point, if there is any abnormality in active secretion of conjugated bilirubin within the canaliculi, that will cause the stasis of conjugated bilirubin within the canaliculi? Yes or no? Yes. There will be two hereditary conditions associated with it. বলতে পারবে? তোমাদের কেউ বলবে? বলো? Rubin Johnson and Rotor. Exactly. Rotor syndrome. These two causes are associated with defect in the active secretion of conjugated bilirubin within the canaliculi. And there are some other conditions where the canaliculi itself is abnormal. বলতে পারবে কেউ? Any canaliculi itself is abnormal. In canaliculi morphology, one is benign hereditary recurrent cholestasis. Second, fibrocystic diseases of pancreas. Pan means pancreas. And third, cholestasis during pregnancy. These three are the conditions, the very important conditions where there will be defective canaliculi itself. Cholestasis during pregnancy. Benign hereditary recurrent cholestasis. Second is fibrocystic disorder of pancreas. Fibrocystic disorder is a large heading. Fibrocystic disorder of pancreas, liver, lung, etc. This is a large heading. So among the extrahepatic causes, the most important, কি বলেছিলাম, either there will be, the most important is obstruction. So obstruction might be in different level. Either there is an obstruction related to the hepatic duct or the common bile duct. So if there is an obstruction in the hepatic duct, what might be that obstruction? Most common cause of obstructive jaundice, gallstone. Beautiful. The most common cause of gallstone. Second, next, আর কিসের জন্য obstruction হতে পারে? একটু জোরে বলো। Portal obstruction of why there is a portal obstruction, extrahepatic portal obstruction, for why, for any, what kind of reason behind that? Portal hypertension cannot cause an obstruction. It is an effect. It is an effect of that obstruction. Exactly, growth involving obstructing any lumen. If it is an growth of hepatic duct carcinoma, which is known as cholangiocarcinoma, or carcinoma in head of pancreas, which causes an annular growth within the pancreas. Exactly, at the ampulla of Vater. So at the point of opening of common bile duct, there will be, if there is any obstruction, the bile cannot go, and it will cause the reflux action of bile. It will spread retrograde direction through the common hepatic duct into the hepatic duct into the liver itself, and other Other than these three conditions, if there is any inflammatory stricture, suppose there will be an inflammation. What kind of inflammation? Inflammation associated with the common bile duct or common hepatic duct is ascending cholangitis. There is known as an pentad, which is known as fallot pentrad. Fallot pentrad. What are the component of fallot pentrad? Surgery case eta. Triad আছে আর পেন্টাড আছে, কি কি ট্রায়াড আছে? Gallstone, hepatic jaundice and right hypochondrial pain. And if there is any fever and there is rise of temperature, these two, pain and rise of temperature, it is fallot pentrad. These are all associated with the ascending cholangitis. So if there is any ascending cholangitis, and secondary to the ascending cholangitis, if there is inflammatory stricture, there might be extrahepatic obstruction. And the fifth important, very important cause is hepatic hereditary causes. Congenital atresia of common bile duct or common hepatic duct. Congenital atresia of common hepatic duct. So ultimately, what are the causes of extrahepatic biliary obstruction? The most important cause is gallstone. Second, the carcinoma, either involving the head of the pancreas or involving the common bile duct, cholangiocarcinoma or carcinoma of head of the pancreas, which is causing the obstruction in the ampulla of bladder. Third, ascending cholangitis and the consequence of ascending cholangitis, inflammatory stricture. Fourth, and fifth, congenital atresia of common hepatic duct. So what are the features of conjugated hyperbilirubinemia? What are the features of conjugated hyperbilirubinemia? How can you differentiate the unconjugated from conjugated? যখনই কোনো গলস্টোন নিয়ে কোনো পেশেন্ট প্রেজেন্ট করবে এবং সেখানে হাইপারবিলিরুবিনিয়া পাবে, তখন দুটো জিনিস সবসময়ই পাবে। ওয়ান, রাইট হাইপোকন্ড্রিয়াল একটা পেন পাবে, অ্যান্ড সেকেন্ড, ক্লে কালার স্টুল। So first point, clay color stool. Second, there will be huge amount of the bile salt within the blood, and this bile salt can get deposited within the skin, and it will cause extensive intrusive pruritus. So excessive bile salt causing the excessive amount of pruritus also. So bile salt accumulation within the body causing pruritus. Third, there will be association of hyperlipidemia and hypoprothrombinemia. Hyperlipidemia and hypoprothrombinemia. And P time will be prolonged. But mainly, these clinical features are associated with intrahepatic causes of hyperconjugated bilirubinemia. These are basically intrahepatic causes of hyperconjugated bilirubinemia. How can you differentiate from intrahepatic to extrahepatic causes? Of course, if there is decreased amount of the bile within the small intestine, the main function of bile within the small intestine is to formation of some micelle, and that micelle will help for fat absorption, and within the at the time of the fat absorption, some important vitamins also get absorbed, which are the lipid soluble vitamins. What are those vitamins? Vitamin A, D, E, K. So if there is decrease in fat absorption in the small intestine and decrease in vitamin A, D, E, K absorption within the small intestine, it will result two things. One, steatorrhea, and second, decreased vitamin K absorption means decreased amount of vitamin K within the body, which causes elongation of prothrombin time. So how can you differentiate? Is it a cause of, it is a consequences of intrahepatic cause or extrahepatic cause? If there is an extrahepatic cause, as a treatment, if you give vitamin K intramuscularly or intravenously, basically usually it is given in the intramuscular route, it will cause normalization of the P time in extrahepatic causes. Keno bolo? Suppose this P time is prolonged. P time is prolonged. Why this? Why? Lack of vitamin K. It cannot get absorbed in the small intestine. ठीक है? So if there is decrease in vitamin K in the blood, the cause might be intrahepatic or extrahepatic, both. But if it is an extrahepatic cause, because the normal secretion is normal, I mean within the bile, the vitamin K can easily pass. So if it is given in intramuscular route, the intrahepatic, in cases of intrahepatic causes of cholestasis, the P time will not go better. There will be no normalization of P time in IM vitamin K. But in cases of extrahepatic causes, if the IM vitamin K is given, there will be normalization of P time, because the canalicular system is okay in such cases. So it causes bypassing of fast metabolism. ठीक? So last point, the diagnosis is made with the help of biopsy, and there are two biopsy, I mean histopathological features in intrahepatic causes and two features in extrahepatic. Features in intrahepatic causes. One, within the intrahepatic causes, there is basically bile stasis. And second, there will be feathery degeneration of hepatocyte site. First, there will be bile stasis, and second features will be feathery degeneration of hepatocyte. As a consequence of both two, there will be in Advanced cases, portal fibrosis plus biliary. And in cases of extrahepatic causes, the histological, two important histological features is, one, there will be retrograde reflux of bile within the common hepatic duct, which ultimately causes the, there will be necrosis of hepatocyte. Why? This reflux of bile, the bile ultimately go within the hepatocyte and extravasated within the extravasated within the hepatocytes, and it causes ultimately necrosis of hepatocytes. These two important features you can differentiate with the help of these two important features of histopathological examination from intrahepatic with the extrahepatic causes of conjugated hyperbilirubinemia. That's it. এইটুকুই সিলেবাসে আছে তোমাদের। খুব ইজি সাবজেক্ট, খুব ইজি টপিক। Ascending cholangitis means retrograde cholangitis.
Today we will discuss about how the calcium and vitamin D helps in maintaining the bone architecture, bone balance, and the management of osteoporosis and different calcium related diseases. So drugs affecting calcium balance. So this is the this is the chapter where you will learn about how we can manage where there is some bone problems. The most common bone problem in our country or in whole of the world is the osteoporosis. So osteoporosis means diminished bone quality, diminished bone architecture. That leads to more incidences of the fracture, more fracture risk. And this osteoporosis is most common in the elderly age group. Okay. So in osteoporosis, we can divide this either as primary osteoporosis or secondary osteoporosis, like any other disease. So primary osteoporosis can be again divided into involutional osteoporosis type 1 or type 2. Involutional osteoporosis type 1 mainly occurs in the postmenopausal women. That is, osteoporosis is very common in postmenopausal women after menopause. And involutional osteoporosis type 2 mainly occurs in the elderly age group, and the incidences are more when the age is more than 50 years. So primary osteoporosis, remember, most commonly occurs in the postmenopausal women and in the elderly age group, mainly when the age is greater than 50 years, both in case of the male as well as in the females. And secondary osteoporosis occurs due to a myriad of conditions. There may be different types of the lifestyle diseases like more alcohol intake, more tobacco, more caffeine. There may be different types of the chronic diseases like hyperthyroidism, diabetes mellitus, different types of the glycogen storage disease. So Cushing syndrome, different types of the endocrine disease. There are many diseases that can lead to more chances of osteoporosis, most chances of the fracture. And there are different types of the drugs also. For example, corticosteroids. Steroids are very notorious for causing fractures. So more PPI intake, that is the proton pump inhibitor, you know, like pantoprazole, rabeprazole, etc. When they are taken for a long period of time, that is chronic PPI intake is an important risk factor for osteoporosis. Corticosteroid taken in the last 5 years, that is when the prednisolone dose is greater than 5 milligram per day for minimum 3 weeks or equivalent dose of any corticosteroid, if taken in last 5 years, that tremendously increases the risk of osteoporosis or risk of fracture. like this, anti-epileptic drugs, different types of the anti-epileptic drugs. So there may be different conditions that can also increase the risk of fracture, increase the risk of osteoporosis. Now this osteoporosis basically means there is deterioration of the bone quality and bone architecture. Now this bone architecture, how this bone mineral density is normal or not, can be diagnosed by a test. This is known as the dual energy X-ray absorptiometry, or in short it is known as the DEXA scan. It is available, okay. So DEXA scan or dual energy X-ray absorptiometry, by this we can measure the bone mineral density of an individual, that is total bone and in total mineral present in all of the bones, that can be measured. Now it is usually expressed as a score, and this score is made in comparison to a standard score, okay. So if this score is less than 2.5 standard deviation than the normal standard ratio that is present in the women, that is known as the osteoporosis, that is 2.5 less than the standard deviation. So you know about the mean and standard deviation. So if we measure number of the variables and take the mean, there will be standard deviation in two sides that will include the other variables. So if it is less than 2 standard deviations below mean, 2.5 standard deviation, that is known as the osteoporosis, and if it is less than 1.5, that is known as the osteopenia, that is the bone mineral density is less. So when the bone mineral density is lesser, there will be more chances of the fracture. So this is about the osteoporosis, and this osteoporosis can be treated or can be prevented by different types of the drugs. The most important part of this osteoporosis that can happen due to some calcium vitamin D metabolism compromise. So calcium vitamin D, they usually work side by side. Calcium is an important part of the bones and also phosphate, and vitamin D mainly helps in the absorption of this calcium. So this is the physiological roles of the calcium. I am not going into the details, you know about this in the physiology. So there are myriad roles. There are roles in the different types of the muscles, regulation of the cell membrane, hormones, autocause transmitter, intracellular messenger, impulse generation, and lastly the structural functions of the bone and teeth in the form of the hydroxyapatite. So now coming to the calcium level. So in the body, in the males, the calcium level is approximately 1300 gram, in the females approximately 1000 gram, and greater than 99% is present in the bones and teeth, and it is regulated by the three hormones, this calcium vitamin D metabolism. One is parathormone or parathyroid hormone, next is calcitonin, and lastly is the calcitriol. Calcitriol is the active form of the vitamin D. So remember, calcium vitamin D is regulated by these three hormones, parathyroid hormone or parathormone, calcitonin and calcitriol, which is the active form of vitamin D. Normal serum calcium level is 8.5 to 10.4 milligram per deciliter, of which 40% is bound to plasma protein, 50% is free ionized, and this is the important form. So free ionized calcium is the most important form, and ultimately that can be increased or decreased, that leads to either hypocalcemia or hypercalcemia. So this is the circulating calcium, ionized calcium or free calcium, which is the physiologically relevant component, mediates calcium's biological effects and can be directly measured. Now when there is acidosis in our body that favors ionization, that is more free calcium positive ion is available in our body, while alkalosis disfavors ionization. So when there is hyperventilation, that is when there is increased respiratory distress, that can precipitate decrease of the calcium, that is the tetany can be precipitated. When there is severe decrease of the calcium, that is known as the hypocalcemia, that can lead to tetany. So pharmacokinetic details is not required, but just remember it is absorbed from the small intestine, and there are different types of the components in the food that can either retard or accelerate the absorption of the calcium. For example, phytates, phosphate, oxalate and tetracycline reduce the absorption, while glucocorticoids and phenytoin reduces calcium absorption. They are filtered to glomerulus, vitamin D increases and calcitonin decreases reabsorption in the proximal tubule. Parathyroid hormone also increases the distal tubular reabsorption, and adequate intake, that is the maximal intake in case of the adolescents is 1300 milligram per day, in adults 1000 milligram per day, and after age 50 years approximately 1200 milligram per day. So on an average 1000 milligram per day calcium intake is necessary for our normal functions to occur. So there are different types of the calcium preparations like calcium chloride, calcium carbonate, of which the calcium carbonate is the most cheap one and available, calcium gluconate, calcium lactate, calcium dibasic phosphate, and calcium chloride. So different types of the salts are present, of which you can see calcium carbonate contains approximately 40% calcium, very high. It is insoluble, tasteless, and non-irritating, reacts with gastric HCl to form chloride, and can be used as also an antacid. Calcium chloride is also used irritant, it cannot be given intramuscular or IV. But this calcium gluconate can be given by injections. When there is severe hypocalcemia, when the calcium level is very less, we have to give calcium by injectable forms, and that can be given by calcium gluconate. Okay. So where this calcium are used, direct only calcium. First is tetany. So when there is severe hypocalcium, calcium level is very less. Normal calcium level in the serum is between 8 to 12. When it is very less, then we have to use the injectable form of the calcium, most commonly the calcium gluconate. 10 to 20 ml IV over 10 minutes, followed by 50 to 100 ml of the calcium gluconate solution over 6 hours. And when their tetany happens, we have to give some supportive treatment also, like oxygen inhalation, IV fluids, etc. Of course, the adequate intake already we have seen. So when there is growing children or pregnancy or lactating, menopausal, etc., dietary supplement is needed, because there will be more need of the calcium. Also in men and women who reduce the bone loss, mainly in the elderly age group. Osteoporosis, of course, the calcium is an important part of the management as well as the prevention of the osteoporosis. Calcium and vitamin D usually used in combination. Empirically in dermatosis, paresthesia, weakness, there is inexplicable weakness or dermatosis or paresthesia, that is the sensation is somewhat different. In these cases calcium can be used, and in some cases antacid, as antacid. So you can see this is the Trousseau sign, which can be seen in case of the tetany. When there is severe hypocalcemia, there will be undue hyperflexion and hyperextension of different metacarpo and carpophalangeal joints, and this is known as the Trousseau sign, by which the hypocalcemia can be diagnosed. Phosphate is also part of this bone, essential component of all body tissues. Greater than 80% present in bone exist in organic and inorganic form. Details is not required, but remember, in bones calcium is usually present as hydroxyapatite with complex with phosphate. So calcium and phosphate usually happens within the bones side by side as hydroxyapatite. Now coming to the vitamin D. So vitamin D is actually a hormone, it is not vitamin, because it mainly regulates the different functions of our body. It is synthesized in mammals, and under ideal conditions it is not required in diet, vitamin D. Vitamin D is the collective name given to anti-rachitic substance. Anti-rachitic means those substances that in the historical it has been seen to prevent the rickets. That's why it is known as the anti-rachitic substance, synthesized in the body and are found in the foods and activated by the ultraviolet radiation. So vitamin D in the 1930s, it has been seen that when there is no sunlight or there is decrease of the sunlight, mainly in the Arctic region, there will be more chances of the bones architecture deterioration. This is known as the rickets in case of the children and osteomalacia in case of the adults, and it can be treated by the vitamin D supplementation. That's why it is known as the anti-rachitic substance. So it can be divided into D3, D2 and D1. Vitamin D3 is also known as the cholecalciferol, which is synthesized in the skin under the influence of the ultraviolet rays. D2 is also known as the argocalciferol. It is present in the irradiated foods, that is foods which are given ultraviolet radiation, yeast, fungi, bread, milk, etc. And D1 is basically a mixture of different anti-rachitic substance. It is not used now, previously it was used. So calcitriol is the active form of the vitamin D, and it is the physiologically important form. It is released from liver in blood and binds to specific vitamin D binding globulin. So you can see this is the activation and synthesis of the vitamin D. So 7-dehydrocholesterol, which is synthesized in the skin, and this by means of the ultraviolet light, it is converted to cholecalciferol, which is also known as the vitamin D2. Then this cholecalciferol comes to the liver microsomes. Within the liver microsomes, 25 hydroxylation of this cholecalciferol happens. Then the 25 hydroxy D3 is formed, also known as the calcifediol or 25 hydroxy cholecalciferol. Then it comes to the kidney, where in the kidney mitochondria 1 hydroxylation again occurs. Then it is converted to calcitriol, which is also known as the 125 dihydroxy vitamin D3. Similarly, in ergosterol is present in the yeast, bread, milk, etc. When it is irradiated, that is the ultraviolet rays is given, it is converted to calciferol, which is vitamin D2. Again, in the same way in the liver microsomes, 25 hydroxylation occurs, 25 hydroxy D2. In the kidney mitochondria, 1 hydroxylation again occurs. So 2 hydroxylation, 125 dihydroxy vitamin D2. So this 125 dihydroxy vitamin D3 and 125 dihydroxy vitamin D2, these are the active forms, of which the calcitriol is formed in our body by means of this mechanism, and it is present in the foods from outside. So that's why calcitriol is the main active form in our body. So it is clear. So it is formed in these 3 steps. So first step is the ultraviolet light, second step is the liver microsomes, and third step is the kidney mitochondria. So from the ultraviolet light, it is converted to vitamin D3 and D2, and in the liver microsomes and the kidney mitochondria, 1 and 25 hydroxylation happens, and ultimately 125 dihydroxy vitamin D3 and D2 are formed. Remember, very important, 125 dihydroxy vitamin D3. It is the active form, and it is also known as the calcitriol. So where it is obtained source? So sunlight is the most important source. Already we have seen. So when there is ultraviolet ray from the sunlight, ultimately the steps started. So not found naturally in many foods. Only in selected foods it is present, synthesized in our body. In the plants, mainly ergosterol is present, and from the ergosterol, vitamin D2 is formed. Fruit milk products are usually fortified with vitamin D. Now you can see the different milk are fortified with vitamin D, so that there will be no vitamin D deficiency. And apart from this, vitamin D is present in the oily fish and fish liver oil, egg yolk, butter, liver, and of course, like vitamin B2, vitamin D3 is less in cases of some strict vegetarians. So where the calcitriol is used, actions of the calcitriol. So first and most important part of the calcitriol is the enhancement of the absorption of the calcium and phosphate from intestine. So calcium and phosphate is an important part of bone development, and not only bone, different other physiological conditions. Vitamin D helps in the absorption of this calcium and vitamin D from the intestine. So how it helps? By increasing the synthesis of the calcium channels. More calcium channels are synthesized, and the carrier are more synthesized, known as the calcium binding protein or calbindin. That is, more calcium channels, more calbindin proteins are synthesized, so that more calcium can be trapped. Analogous to the steroid hormones, it binds to cytoplasmic vitamin D receptor. Translocation increase synthesis of the mRNA regulation of the protein synthesis. So increased synthesis of the vitamin D receptors also happens, and ultimately a cycle continues. So activation of the vitamin D receptor promotes endocytotic capture of the calcium and transport across the duodenal mucosa. That's why even if the vitamin D usually takes time for synthesis, when it is given in severe hypocalcemia, the action is also quick, because the activation of the vitamin D receptor promotes the endocytotic capture. That is, within the endocytosis, more calciums are captured by this vitamin D receptor, and it is transported across the duodenal mucosa. That is, more absorption of the calcium happens instantaneously when the vitamin D is given. Apart from this, it also enhances the recruitment and differentiation of osteoclast precursors for remodeling. So in the bones, you know, there are osteoblast cells and osteoclast cells. So there will be development of the bone and resorption of the bone continuing, and it is a cycle. So after resorption, again the development or more bone addition happens. So if there is no resorption, there will be dismantled bone, or there will be deranged bone function. So ultimately, recruitment and differentiation of osteoclast precursors, so that more osteoclast cells will be there for remodeling. This process is known as the remodeling of the bone, and this remodeling is continual. So resorption of the calcium and phosphate from bone also happens. So calcium and phosphate from bones, it is reabsorbed within the serum, and ultimately it goes when there is hypocalcemia. So mature osteoclasts lack vitamin D receptor. It induces rank ligand. So rank ligand is a receptor for activation of nuclear factor kappa beta ligand. So this is a ligand that is present in the osteoblast, and when it is activated, it activates the osteoclast. So resorption of the bone and development of the bone occur side by side, and this resorption of the bone is helped by the vitamin D. Ultimately, that leads to laying down and mineralization of the osteoids. It mainly appears to help bone mineralization indirectly by maintaining the normal plasma calcium and phosphate concentration, and its action is independent of but facilitated by the parathyroid hormone. It also enhances the tubular reabsorption of the calcium, that is in the kidney. When more calcium influx occurs, some part of the calcium is resorbed back to our body. Apart from this, the other actions of the vitamin D are lymphokine production, proliferation and differentiation of epidermal and certain malignant cells, neuronal, skeletal muscle function, etc. So vitamin D is also absorbed from the intestine in presence of the bile salts, mainly by lymphatics. Details is not required, but it is well absorbed in our body. So how it is prepared or unitage is happens. So 1 microgram of cholecalciferol is equivalent to 40 international unit of vitamin D. Vitamin D is usually given as an international unit. So normal requirement is approximately 400 international unit per day, and it is increased when there is less of sunlight or when there is increased demand. It is increased to approximately 800 international unit per day also. So calciferol, cholecalciferol, calcitriol, these preparations are available in our body. So calcitriol analogs are also present. Alpha calcidol, like it is present, it is a product rapidly hydrolyzed to calcitriol in liver. Calcipotriol, doxcalciferol, pericalcitol, etc. So these are the different preparations that is used, present in the market. So where it is used, vitamin D use. Firstly, the prophylaxis and treatment of rickets and osteomalacia. Only when there is vitamin D deficiency, already I have told that there will be either rickets in the children or osteomalacia in case of the adults. So the prophylaxis is approximately 400 international unit per day. So this is the requirement. And treatment means there is large dose of the vitamin D is required. Approximately 3000 to 4000 international unit per day is required. Alternatively, oral or IM injections 3 to 6 lakhs international unit every 2 to 6 months interval can also be given. So injectional preparations of the vitamin D is also present. It is given either 2 monthly or 6 monthly interval. Metabolic rickets. So rickets may also happen not due to the direct vitamin D deficiency, but due to the deficiency of the actions of the vitamin D due to some metabolic problems in our body. So this can be divided into vitamin D resistant rickets, vitamin D dependent rickets, and renal rickets. So what is this vitamin D resistant rickets? Basically it's the hereditary disease, X-linked hereditary disease, in which the vitamin D metabolism is normal, but calcium and phosphate metabolism is deranged. So phosphate with high doses of the calcitriol is required for the management of vitamin D resistant rickets. That's why resistant. So if we are giving only vitamin D, the rickets will not be cured. We need also phosphate. Then is the vitamin D dependent rickets. So this is another genetic disorder due to deficiency of the renal hydroxylating mechanism. So already we have seen in the second step, renal 25 hydroxylation happens. So if this 25 hydroxylation mechanism is deranged by some renal problems or other problems, then vitamin D dependent rickets may develop. So administration of calcitriol or alpha calcidol is effective in normal doses. And apart from this vitamin D resistant rickets and vitamin D dependent rickets, there are renal rickets. So renal rickets means conversion of 25 hydroxy vitamin D3 into calcitriol does not occur due to chronic renal disease. So when there is chronic kidney disease or chronic renal disease, mostly that can happen due to some diabetes mellitus or other kidney related problem that leads to renal rickets. So calcitriol or alpha calcidol or dihydrotachisterol are needed in usual doses. So when there is increased kidney disease, always we have to supplement with some vitamin D preparations because if we are not supplementing, that can lead to renal rickets. So usually prophylactically vitamin D is given. So these are the rickets and osteomalacia. These are the metabolic rickets. There are three types of the metabolic rickets. Apart from this, it is used in the senile or postmenopausal osteoporosis. Already I have discussed. So there may be involutional osteoporosis, type 1 and type 2, either in the postmenopausal or in the senile age group. In those cases, it is used. When there is hypoparathyroidism, that also vitamin D is required. Fanconi syndrome is another hereditary disease. Here the vitamin D can raise the lower phosphate levels that occurs. And psoriasis. In the psoriasis, different types of the vitamin D ointment and vitamin D medications are also used, like calcipotriol. It is a vitamin D analog which is used in the management of the psoriasis. Psoriasis is a skin conditions where it can be used. So vitamin D deficiency. So pure vitamin D deficiency leads to rickets in small children and osteomalacia in adults. So what is in rickets? So in rickets, mainly different types of the osseous changes occurs, like in the heads, craniotapes, frontal bossing, box-like skull, etc. occurs. In teeth, delayed erection of the teeth. In chest, there is rachitic rosary, pigeon chest for funnel-shaped chest. In spinal column, scoliosis, kyphosis or lordosis. That is there are different bending of the spinal cord will be deranged. Bow legs, the normal angle of two legs are deranged. Rachitic dwarfism, that is the total height is also shortened. In the muscular system, pot belly, motor development is delayed, and different other nervous and mental symptoms can also develop in rickets. So you can see it is a normal picture of a rickets. You can see this is a pot belly, rachitic rosary, pigeon chest. This is the pigeon chest like this. So this can happen when there is vitamin D deficiency. So this is rickets. So you can this is the bow legs. So normal angle between the two legs are changed when there is vitamin D deficiency. This is the bow legs. You can see the curvature is changed. So the treatment, so apart from the food and nursing care, prevention of complications, vitamin D therapy and different types of the vitamin T injections are also given. Dose is not required, and prevention is important. Pregnant and lactating women should take adequate amount of the vitamin D because vitamin D requirement is increased in pregnancy and lactating women. Advocate sunbathing, advocate breastfeeding, and vitamin D supplementation is required when there is premature twins and weak babies. So more dose, you can see 800 international unit per day is required. For term babies and infants, 400 international unit per day, and for those babies who can't maintain daily supplementation, we have to give intramuscular injection of the vitamin D. And apart from with vitamin D, of course, we have to give the calcium supplementation also. So this is the osteomalacia in case of the adults. So osteomalacia is basically incomplete mineralization of normal osteoid tissue. So osteoid tissue is normal, but the mineralization is deranged following closure of the growth plates. So growth plate closure does not happen in case of the children. After the adolescent age group, the growth plate closure occurs. So if the growth plate closure occurs and after that the mineralization becomes incomplete, that leads to osteomalacia. Ultimately, the consequence is the soft bone pain, bone fracture, compressed vertebra and muscle weakness. So this is the X-ray epilateral view. So there is generalized osteopenia and you can see a lucency, that is the increased radiation here. This is the linear lucency, this is known as the loser's zone. So when it is seen, it is the indicative of the incomplete mineralization after the growth plate closure, and it is the indication of the patient having osteomalacia. So we have to treat with the vitamin D. So apart from this, if high amount of the vitamin D is given, that also leads to hypervitaminosis D also. When acute or long-term administration is done, it causes hypercalcemia. So calcium level is increased, that leads to nausea, vomiting, excessive thrust, joint muscle pain, disorientation, coma, etc. etc. Again, details is not required. Hypercalcemia can be diagnosed again in the ECG. There will be Osborne wave. So there will be tweak after the QRS complex in the limb leads. B5 is the limb lead. So it indicates that there is hypercalcemia, and that leads to this Osborne wave. So recommended daily allowance already discussed, not required. So now coming to the parathyroid hormone. So parathyroid hormone is very important. It is present posterior to the thyroid gland, and there are 4 numbers of the parathyroid. It is secreted by the principal cells of the parathyroid gland. So within the parathyroid gland, within the parathyroid gland there are parathyroid principal cells, and from these principal cells parathyroid hormone is secreted. From the pre-parathyroid hormone, proparathyroid hormone is secreted, and from this proparathyroid hormone, parathyroid hormone is ultimately synthesized, which is a 84 amino acid polypeptide. Hypocalcemia is a principal factor regulating the parathyroid hormone synthesis and release. That is the calcium level in the serum. When it is very low, ultimately there will be more secretion of the parathyroid hormone and vice versa. And how this parathyroid hormone acts? The primary function is to maintain a constant concentration of the calcium and phosphate in the extracellular fluid. So within the extracellular fluid, the calcium and the inorganic phosphate should be normal. And if it is either less or more, parathyroid hormone is secreted or less secreted, and ultimately it leads to a balanced position. The principal processes regulated are renal calcium and inorganic phosphate absorption and mobilization of the bone calcium. So plasma calcium is the major factor regulating the parathyroid hormone secretion. So when the concentration of the calcium diminishes, parathyroid hormone secretion increases, and vice versa. So where it acts in the 3 areas. First is bone, next is kidney, and last is intestine. So in the bone, parathyroid hormone promptly increases the resorption of the calcium from bone. That is, from the bone calcium is resorbed. It comes out, and again, so that there will be more bone formation later. So this will be a cycle. This is the most prominent action of the parathyroid hormone, exerted by increasing the number of bone remodeling units and activating osteoclasts when high concentrations are present continuously. Since bone resorption is followed by new bone deposition, so basically it is a cycle. After the bone resorption, bone deposition occurs. This is also promoted by the parathyroid hormone. Increased bone formation occurs when parathyroid hormone is given intermittently and in low doses. Parathyroid hormone is given in the injectable route, and when it is given in the low doses in the intermittently, resorption happens and ultimately bone deposition occurs more. In the kidney, parathyroid hormone increases the calcium reabsorption in the distal tubule. So within the kidney there are distal tubule from which the reabsorption of the calcium back to the body happens. Parathyroid hormone increases this reabsorption, provides moment to moment regulation of the calcium excretion. Apart from this, it also promotes phosphate excretion, which tends to supplement the hypercalcemic effect. So in the intestine, parathyroid hormone has no direct effect, but it indirectly helps by enhancing the formation of calcitriol, that is the active form of the vitamin D in the kidney, by activating the 1-alpha hydroxylation. That is, already we have seen in the kidney mitochondria, the last phase of the active vitamin D formation, that is the 1-alpha hydroxylation happens. Parathyroid hormone increases this 1-alpha hydroxylation and ultimately indirectly helps in the calcium absorption. It decreases calcium levels in the milk, saliva and ocular lens secretion, that is more conservation of the calcium in the body. It may be responsible for development of the cataract in case of the hypoparathyroidism. Rapidly metabolized in liver and kidney, and the half-life is 2 to 5 minutes, hence cannot be used therapeutically. So this parathyroid hormone, you can see the half-life is very less, only 2 to 5 minutes. That's why clinically parathyroid hormone per se cannot be used, but recombinant form has been formed. Recombinant parathyroid hormone, also known as the teriparatide. So teriparatide can be used clinically when there is parathyroid hormone deficiency. So it stimulates new bone formation on trabecular and cortical bone surfaces by preferential stimulation of osteoblastic activity over osteoclastic activity. And daily subcutaneous injections for treatment of the severe osteoporosis is usually given. So teriparatide injections is available. Daily subcutaneous injection is given when there is severe osteoporosis. So there is severe quality of the bone is compromised. Diagnostic use, it can use to differentiate pseudo and true hypoparathyroidism. That is, from the parathyroid gland, parathyroid hormone is secreted less. Whether it is true hypoparathyroidism or pseudo hypoparathyroidism can also be delineated by giving the teriparatide injections. Side effect is occasional headache, dizziness, leg cramps. So this teriparatide can also be used for the treatment of osteoporosis apart from calcium, vitamin D. Now coming to the cinacalcet. Cinacalcet is a drug which is basically also known as the calcimimetics or calcium sensor mimetics. Basically it senses the calcium, activates the calcium sensing receptor CASR. This calcium sensing receptor is present in the parathyroid gland. So parathyroid gland, already we have seen, they basically helps in maintaining balance of the calcium in our body. So there are calcium sensing receptor within the parathyroid gland that senses whether the calcium level in our body is less or more, and accordingly the parathyroid hormone is secreted. So parathyroid hormone, when it is secreted, we have already seen that acts on the bone, that acts on the kidney, and that acts indirectly on the intestine to help conserve more calcium in our body. In the bones, they help in the resorption of the calcium from the bones back to the serum or back to the body. Again in the kidney, it helps in the 1-alpha hydroxylation. Again in the intestine, they also helps in the vitamin D to capture more calcium. So basically this cinacalcet activates this calcium sensing receptor and enhances sensitivity to extracellular calcium and blocks parathyroid hormone secretion. It is indicated in secondary hyperparathyroidism. So parathyroid gland, from the parathyroid gland, parathyroid hormone is secreted more, but due to some secondary causes, this is known as the secondary hyperparathyroidism, mostly happens due to some kidney diseases and also in the parathyroid tumor. Here we need the cinacalcet so that it activates the calcium sensing receptor. Adverse effect is of course the hypocalcemia, because they basically decrease the calcium conservation power in our body. So it is used when there is more parathyroid hormone secretion from the parathyroid glands. So cinacalcet. So this is the hypo and hyperparathyroidism. So hypoparathyroidism, that is from the parathyroid gland, the hormone is secreted less. So ultimately that leads to low plasma calcium level. When there is low parathyroid hormone, there will be low calcium level in our body. There will be tetany, convulsion or laryngospasm can happen. Paresthesia, cataract and psychiatric changes can also happen. There is another term known as the pseudo hypoparathyroidism that mainly happens due to the receptor level, due to the reduced sensitivity of the target cells to parathyroid hormone and caused by a mutation in the G-protein coupled receptor. Details is not required. And apart from this, another is hyperparathyroidism, just opposite of the hypoparathyroidism, that may happen due to some parathyroid tumor. So when there is tumor, there will be more parathyroid hormone secretion. So there will be hypercalcemia, because more calcium is consumed in our body, so there will be more calcium. So decalcification of the bone, because there will be more resorption of the calcium from the bones. That is not normal. So deformities and fractures again can happen. Metastatic calcification, renal stone, muscle weakness, constipation, anorexia, all can happen. So hyperparathyroidism can typically also leads to increased fracture risk, okay, because there will be more resorption of the bones. That is not normal. Normal resorption and deposition of the bones are in the cycle, but when there is more parathyroid hormone in our body, there will be more resorption and less deposition of the bones, so that there will be more chances of the fracture. So treatment is surgical removal of the parathyroid tumor. When it is not possible, low calcium, high phosphate diet with plenty of the fluids is advised. In hyperparathyroidism, there is also constipation. Severe constipation happens. That's why more fluid is required in our body. So this is the calcium homeostasis. In short, you can see this is the 4 parathyroid glands. These parathyroid glands are present posterior to the thyroid gland. Parathyroid gland secretes the parathyroid hormone. This parathyroid hormone can acts on the kidney and on the bone. In the kidney, they decreases the urinary calcium excretion. That is, calcium is reabsorbed back. They causes increased urine phosphate. That is, phosphate is relieved from our body, and ultimately they will be helps in the more calcitile formation. In the bones, they causes the resorption of the bones. That is, there will be more plasma calcium, and this calcitriol that is released also causes the resorption of the bone, so there will be more calcium. And this calcitriol in the intestine, they also causes increased phosphate absorption and increased calcium absorption. All this leads to increased plasma calcium, and this increased plasma calcium by means of the feedback inhibition causes decreased secretion of the parathyroid hormone. So when the calcium level becomes normal in our body, the parathyroid hormone again secretes the less parathyroid hormone. So this is the calcium homeostasis and regulation. You can see. So parathyroid hormone, vitamin D, calcium, this kidney, bones and intestine or are in synchrony to maintain a normal calcium level in our body, normal vitamin D in our body as well as normal parathyroid hormone in our body. So again the same thing. So when there is decreased plasma calcium concentration, the parathyroid hormone secretion is increased. That leads to increased plasma parathyroid hormone concentration. That leads to decreased renal tubular reabsorption of the phosphate, increased urinary excretion of the phosphate and decreased plasma phosphate concentration for the phosphate part. It causes increased bone resorption. So there will be increased release of the calcium into plasma, increased renal tubular reabsorption of the calcium back to the body. So there will be decreased urinary excretion of the calcium, less urinary excretion of the calcium. So there will be increased formation of the active form of the vitamin D3 in the kidneys. So there will be increased plasma concentration of the calcitriol 125 dihydroxy vitamin D3 in our body. That causes increased intestinal absorption of the calcium, and all this leads to restoration of the plasma calcium concentration towards normal. So this is very important, how the calcium, vitamin D and parathyroid hormone acts in synchrony in maintaining the normal calcium balance, normal vitamin D balance, where the parathyroid hormone acts mainly 3 places and how this balance is maintained. Next, coming to the calcitonin. Calcitonin is another hormone which is a peptide hormone secreted by the parafollicular cells or C cells lying in the intestinal fluid between the follicles of the thyroid gland. So calcitonin is secreted from the thyroid gland and parathyroid hormone is secreted from the parathyroid gland that is present posterior to the thyroid gland. So remember, do not confuse. Calcitonin is secreted from the thyroid gland. So it is secreted from the C cells of the thyroid gland or parafollicular cells of the thyroid gland. So parathyroid hormone is secreted from the parathyroid gland and calcitonin is secreted from the parafollicular cells of the thyroid gland. Okay. So this is a 32 amino acid single chain peptide. Basically it tends to decrease the plasma calcium concentration. So remember, the action of the calcitonin is just opposite of the parathyroid hormone. Opposite of the parathyroid hormone. So it decreases plasma calcium concentration, opposite action of the parathyroid hormone. It is the most potent peptide inhibitor of the osteoclast mediated bone resorption. So this bone resorption is prevented. Okay, helps to protect the skeleton during periods of the calcium stress. So such as growth, pregnancy and lactation. So basically all these are maintained in balance. So parathyroid hormone, calcitonin, they are maintained in balance. The action is just opposite. Synthesis and secretion of the calcitonin is regulated by plasma calcium concentration itself. Again, when there is rise of the plasma calcium concentration, so there will be fall in plasma calcium concentration, decreases the calcium release. So just opposite. So parathyroid hormone secretion will be more when the calcium concentration in our body is less, but the calcitonin concentration is less when the plasma calcium concentration is less. That is similar. Circulating level of the calcitonin is low, its physiological role is minor. The plasma T half is 10 minutes, but its action lasts for several hours. So calcitonin decreases the blood calcium ion concentration rapidly within minutes after injection of the calcitonin. So action of the calcitonin is inhibits the bone resorption by direct action on osteoclast, opposite of the parathyroid hormone, inhibits the proximal tubular resorption of the calcium and phosphate by direct action on kidney, just opposite of the parathyroid hormone. Action is mediated to G-protein coupled calcitonin receptor, but target cells are different from that of the parathyroid hormone. So there are different preparations of the calcitonin present. So porcine or natural calcitonin is antigenic, that's why it is lesser used nowadays. Usually synthetic salmon calcitonin is used. So this calcitonin is obtained from the salmon fish, more potent and longer acting due to slower metabolism. Synthetic human calcitonin, 1 international unit is 4 microgram of the standard preparation. Calcitonin is given by subcutaneous or intramuscular routes, and remember salmon calcitonin is also available as nasal spray. So if you are asked that example of a nasal spray, so calcitonin nasal spray is very commonly used. It can be given salmon calcitonin by nasal spray, it can be given. So where this calcitonin is used? When there is hypercalcemic states, that is calcium level is high, hypercalcemia, and this hypercalcemia occurs, already we have seen, when there is hyperparathyroidism. So from the parathyroid gland, parathyroid hormones is more secreted due to some parathyroid tumor that leads to hypercalcemia, hypervitaminosis D. So already we have seen when there is more taking of the vitamin D, osteolytic bony metastasis in case of the cancer, it has been seen, and hypercalcemia of malignancy. Here calcitonin is used. It acts rapidly within 4 hours, response peaks at 48 hours. Paget's disease of the bone. This is another disease where there is disorder of the increased skeletal remodeling. So skeletal remodeling becomes very much deranged in case of the Paget's disease of the bone, and there will be more risks of the fracture. After improvement for few days, later resistance may develop due to production of the antibodies. Here calcitonin can be used. Postmenopausal osteoporosis and corticosteroid induced osteoporosis, it can be used, and diagnosis of the medullary carcinoma of thyroid. So it can be used in the diagnostic purpose also, because it is secreted from the C cells, the parafollicular cells of the thyroid. Adverse effects: flushing, tingling, sensation in fingers, flu-like symptom, allergic symptoms, etc. can occur, but nothing significant, not important. Fibroblast growth factor 23, details is not required. Remember the name FGF23. So this is also invented in the invented stage. Main function is the promotion of the urinary phosphate excretion. So basically it is a hypophosphatemic hormone and the suppression of the active vitamin D production by the kidney. So FGF23 and clotho. So basically this can be used for phosphate conservation. Now coming to the bisphosphonate. So bisphosphonate is very important in decreasing the osteoporosis, in prophylaxis and treatment of the osteoporosis. So bisphosphonate is a non-hormonal agent in calcium homeostasis. Basically they form a 3-dimensional structure capable of chelating divalent cations like calcium and have a strong affinity for bone. This bisphosphonate is very important for your examination. It can come as long question, short note, as well as in the viva. So bisphosphonate is a 3-dimensional structure. It prevents osteoporosis, useful in metabolic bone disease and hypercalcemia, most effective anti-resorptive drug at present. So you can see this is the structure. Basically this is the analog of the pyrophosphate that contains 2 phosphate group attached to a geminal or central carbon. Okay, these are the 2 phosphate group R1 and R2 that are attached to the geminal or central carbon that replaces the oxygen in the pyrophosphate. Now this R1 affects binding affinity to bone and this R2 affects the anti-resorptive capacity. So when this bisphosphonate is given, there are different types of the bisphosphonates, and according to these side chains they have increased or decreased binding affinity to the bone or increased or decreased resorptive capacity to the bone. R1 determines the binding capacity and R2 determines the resorptive capacity and also side effect profile. They vary in potency based on the specific side chains. So there are different generations of the bisphosphonate. First generation lesser is now etidronate, telludronate. Second generation name is pamidronate, alidronate and ibandronate. These are used nowadays. And third generation newer ones are the risedronate and zoledronate. So you can see with each generation the potency of these phosphonates are increased. So you can see zoledronate is very much potent, approximately 5,000 times than the normal etidronate. So these bisphosphonates can be given orally or it can be given in the injectable form. So first generations are minimally modified side chain, second generation contain a nitrogen group and third generation contain a nitrogen atom with a heterocyclic ring, and the efficiency and potency is more in the third generation than the second generation and the first generation. So the mechanism of actions is basically it is easy. So basically they have affinity towards the bone, affinity towards the hydroxyapatite molecule that is present within the bone. So there are two main components of the bone matrix and solid mineral phase. This solid mineral phase is the hydroxyapatite. Bisphosphonates attach in the hydroxyapatite and ultimately in resorptive pits they localize here and accelerated apoptosis of the osteoclast, reducing their number. So osteoclast that ultimately helps in the resorption of the bone that are reduced when these bisphosphonates come and they attach with the hydroxyapatite parts of the bone. So there will be less resorption of the bone, disruption of the cytoskeleton of the ruffled border of the osteoclast. That is, the osteoclast action is decreased when this bisphosphonate is given. So bisphosphonates localize in the acidic zones of the resorptive pits. So within the resorption of the bones there are resorptive pits where it is attached and they are high affinity for calcium ions. This calcium ion released from the bone surface due to high acidity and bisphosphonates also are released. So ultimately they help by increasing the solid mineral phase or hydroxyapatite. Okay. So pharmacokinetics, remember these bisphosphonates are very poorly absorbed in our body and they can lead to different types of the gastric and esophageal irritation when it is taken in the mouth. So hence this drug should be administered with a full glass of water. So how it is administered? I am coming. So how it is administered? Oral bisphosphonates. So it has been seen when oral bisphosphonates are taken in the mouth, they can lead to more esophageal irritation. So usually a full glass of water is taken in the morning time without any food and then it is taken with a full glass of water and the patient is asked to remain upright for minimum 30 minutes to 1 hour after intake of the bisphosphonates. Otherwise, there will be more chances of the esophageal irritation due to gastroesophageal reflux. So tablets must be swallowed whole with a full glass of water on an empty stomach at least 30 to 60 minutes before food while standing or sitting upright, and the patients must not lie down for 30 minutes after administration of the alendronic acid or risedronate. And patients should be advised to stop the bisphosphonate tablet whenever there is some irritation happens. So basically it is used in the treatment of the osteoporosis, both prevention and treatment. Paget's disease already we have seen, details is not required, just remember it is used for the treatment of the Paget's disease, hypercalcemia of malignancy and osteolytic bone metastasis. So individual drugs, now alendronate is available in the as a oral drug in different forms. It is given already, how it is given, it is given. Adverse drug reaction is gastric and esophageal irritation, very important. Risedronate is similar to elendronate, and zolendronate or zolendronic acid is very much potent than the other agents. Usually it is given by injectable forms 6 monthly or 1 yearly, that is for the long period of the time. It suppresses the osteoclastic activity, additional anti-tumor effect, proliferation of the bony metastasis of the prostate, and adverse drug reaction is flu-like symptoms due to cytokine release. So the adverse effects are already I have told that gastrointestinal complications like gastritis, esophageal irritation, these are important. To minimize this gastrointestinal inflammation, the different points that I have discussed, that is, should be taken in the empty stomach in the morning with a full glass of water. The patient has to remain upright for 30 minutes to 1 hour after taking of the bisphosphonate tablet. It should be maintained. And bisphosphonate related osteonecrosis of the jaw or phossy jaw can also happen, but it is rare in some of the cases. Initial parenteral infusion can also lead to skin flushing, flu-like symptoms also, and zoledronate can cause severe hypocalcemia and associated with renal toxicity, etc. So this is about the bisphosphonates. Osteoporosis already I have discussed. There are some things. Just remember these drugs used in osteoporosis. So there may be anabolic agents and anti-resorptive agents. Both are used. Already we have seen that anabolic agents are mainly forms new bones, while anti-resorptive agents usually blocks the resorption of the bone. So bone turnover are accelerated by anabolic agent, anti-resorptive agent is slow turnover. So there are different agents that have dual actions, but mostly we can see that teriparatide, some fluoride agents, androgens like testosterone, they have anabolic effect on the bones, while the bisphosphonates, calcitonin, estrogen replacement therapy. When you will read about the estrogen, you will see selective estrogen receptor modulator. In the estrogen class, you will see this selective estrogen receptor modulator can also be used for the management of the osteoporosis. Calcium, vitamin D, thiazides, all can be used for the treatment of the osteoporosis. So this thiazide diuretic, remember already you have seen in the diuretic that it can be used for that, it can be used when there is more osteoporosis. This diuretic ultimately helps. Remember this strontium ranelate, it basically have dual actions. So oral, it is known as the dual action bone agents, also known as the DABS, dual action, that is it has both anabolic action as well as anti-resorptive action. It is a ranelic acid salt of strontium. Basically they increase the collagen and non-collagen protein synthesis, enhances pre-osteoblast differentiation and decrease osteoclast function. Fluoride details is not required, just remember fluoride is used previously, but due to some toxicity it is not nowadays used. Denosumab, again it is very costly, it is basically a monoclonal antibody of the rank ligand, and this rank ligand activation is important for osteoclast activation. Denosumab just inhibits this osteoclast activation. So denosumab is a human monoclonal antibody that binds with high affinity to rank ligand that mimics the osteoprotectin. This osteoprotectin is the normal physiological ligand of this rank. So basically they are competes with osteoprotectin, they blocks this osteoprotectin action, and ultimately they decreases the osteoclast formation and activation. So denosumab, which is a human monoclonal antibody of the rank ligand that blocks the osteoclast formation and activation, increases the bone mineral density and decreases the bone turnover. So remember the name denosumab is a monoclonal antibody. So prevention of the osteoporosis, regular physical activity, adequate dietary calcium intake. In case of the elderly, the supplementation of the vitamin D and calcium is very important. Timely administration of the estrogen in postmenopausal women, in some of the cases it has been seen to decrease the osteoporosis, and prevention and correction of the hypogonadism, because androgen deficiency is also an important part of the osteoporosis. Lastly, glucocorticoids also leads to osteoporosis. So already we have seen about the steroid class. So glucocorticoids inhibits the osteoblast function and increase osteoblast apoptosis. Ultimately, all these, there are different types of the mechanisms. All this decreases the osteoblast apoptosis, increases osteoblast apoptosis, increase urinary calcium loss, reduction of the adrenal androgens, and induction of the glucocorticoid myopathy happens. And treatment of this glucocorticoid induced osteoporosis, again the bisphosphonates. So when the osteoporosis is usually diagnosed, usually we first supplement with calcium, vitamin D, and when it is not controlled, be it the primary due to the elderly age group or postmenopausal age group, be it the secondary or due to some drugs, most commonly the corticosteroids, we have to start the different other agents. The first agent, the most important agent that is required is the bisphosphonates. So bisphosphonates is very important for your exam also. So after bisphosphonates, There are different types of the agents, and according to the disease pathophysiology, whether the anabolic agent should be used or anti-disruptive agents should be used, we have to use the different agents. For example, when there is hyperparathyroidism related bone fractures, we have to more use the calcitonin. When there is estrogen deficiency more, we have to just give the estrogen replacement therapy or selective estrogen receptor modulator or ACRMs like raloxifene. Raloxifene is a selective estrogen receptor modulator. You will read in the estrogen class, that is also required for the treatment of the osteoporosis. There are different other agents like already we have seen teriparatide or denosumab. Usually it is used in when there is very high risk of the osteoporosis or already there are history of the osteoporosis. So thank you. This is all about the osteoporosis. So within the osteoporosis, already I have told you that the calcium, vitamin D, obviously the vitamin D metabolism, how the calcium, vitamin D is regulated by the parathyroid hormone is very important. Parathyroid hormone is also important for your short notes. Calcitonin is important for your short notes. Treatment, management of the osteoporosis is important for your long questions where you have to write all the different agents including the teriparatide, denosumab, etc. You have to know about the bisphosphonates, everything about the bisphosphonates, how the bisphosphonate acts, what are the different generations of the bisphosphonates, adverse effects of the bisphosphonates, and how the bisphosphonate tablet have to be consumed, that is in the morning time, etc., etc., and what are the adverse effects. So these are the important points.
What are the precursor lesion of colon carcinoma? Before that, most common type of colon cancer. Most common type of colon cancer. 5-6টা কোশ্চেন আছে, অ্যানসার দিতে পারলে পাস করে যাবি সিম্পলি। Most common type of colon carcinoma. Colon cancer, most common type. Histopathological, most common type of colon cancer. আগের দিন গ্যাস্ট্রিক কার্সিনোমা ক্লাস করেছি সবাই। So, exactly, adenocarcinoma. What are the types of gastric carcinoma? Exactly, mesenchymal, epithelial. Other than mesenchymal epithelial, stromal. Other than stromal, শোন আইদার আমার কথাটা শুনবি অথবা বই খুলবি, দুটোর মধ্যে অর, আইদার অর। যদি বই খুলে থাকিস তাহলে বই পড়, না হলে অরিজিন, mesenchymal origin, neuroendocrine origin, lymphoid origin, and other than all. ঠিক আছে? That could be melanoma, that is melanocytic origin. What are the precursor lesion of adenocarcinoma? Polyp, some polyp. So, what are the main types of polyp occurring in colon or small intestine? Exactly, one juvenile polyp. কি সেটা, কি টাইপের পলিপ? These are theory questions, difficult. What are the types of polyp in small intestine? একা কেন সবাই পিছনে, ব্যাক বেঞ্চার পিছনে, why? What are the types of polyp? Types of polyp. Broad classification of polyp. একটা তো জুভেনাইল, জুভেনাইলটা একটা নাম, এক্স্যাক্টলি একটা নাম। কোন হেডিং এ আসে পলিপটা? শোনা গিয়েছিল হাইপারপ্লাস্টিক পলিপ, ইনফ্লামেটরি পলিপ, অ্যাডিনোমাটাস পলিপ। ওকে, সো what are the types of polyp? Juvenile, which kind of polyp? জুভেনাইলটা কোন হেডিং এর মধ্যে আসে? আন্ডার which heading juvenile polyp comes? Hyperplastic polyp. Other than juvenile polyp, another hyperplastic polyp, Creutzfeldt syndrome বলছিলিস, that is one. Inflammatory polyp, direct example. No. Inflammatory cloacogenic polyp of colon. Adenomatous polyp types, tubular, villus. Most common syndrome associated with the presence of adenomatous polyp, adenomatous polyposis coli syndrome, and hereditary polyposis coli syndrome, HNPCC. Okay. So the most common primary etiology or precursor lesion of colonic carcinoma is polyp. These polyp are mainly of two types, from where the coloniocarcinoma usually occurring. That could be adenomatous polyp, that could be serrated polyp, sessile serrated polyp. ওকে, কেন এই দুটোর আলাদা আলাদা ভাগ আছে? Why these are totally different from each other? Why? These are basically usually benign and they are precursor lesion because they have a great chance of malignant transformation. Why these adenomatous polyp and sessile serrated polyps are distinct from each other? No. Polyp mainly দুই টাইপের হয়, তাই তো? Either they have a stalk, they are known as pedunculated polyp, or they don't have any stalk. It is sessile polyp. ঠিক আছে? These are usually pedunculated polyp, but sessile serrated polyp or sessile polyp basically. But these are not the main characteristic different points. Theory class হয়ে গিয়েছে। কোলন ক্যান্সারের থিওরি ক্লাস হয়ে গিয়েছে। কি পড়ানো হয়েছে? কি পড়ানো হয়েছে তোদের এইরকম কেন আছি? What are the etiological factors? What are the factors which responsible for occurring colon cancer? One, smoking, exactly. Alcohol consumption, nitrate consumption, nitrate. But these are not main points. Exactly, but not the main point. High complex fiber, fiber with carbohydrate. Complex fiber, not a single fiber. And high fat intake. Plus low protein intake and low simple fiber intake. Smoking, alcohol, nitrate, high complex carbohydrate intake, low protein intake, high fat intake, and low simple carbohydrate intake. Simple fiber intake. These are the main etiological factors. Okay. There are two distinct pathological features which are associated with the pathogenesis of adenocarcinoma. Basic pathogenesis of adenocarcinoma in two sides, mainly in two parts of the colon. Okay, this is cecum, this is appendix, this is cecum, this is appendix, ascending colon, transverse colon, descending colon, sigmoid colon, and this is anal colon. This whole thing proctosigmoid junction, proctosigmoid portion. This portion up to splenic fissure, and from hepatic flexure. This is right sided, right colon, transverse colon and left colon. If there is any kind of colonic cancer occurring in the right colon, that will cause a proliferating type of growth. Okay, that will cause a proliferating polypoid growth, and that polypoid growth causing bleeding. Why? Because this growth is a very fragile structure and so many neovascularization etc. occurring within the growth inside. So there will be an ulceration in the superficial portion of the polypoid structure, and that will cause, ultimately that will cause bleeding. So if there is any right-sided growth, usually they present as iron deficiency anemia. Why? That could be associated with huge occult bleed, and that occult bleed associated with low iron content in the body. So usually they present with an iron deficiency anemia if there is any right-sided colonic growth. Is it okay? But if the growth occurring in the left side, that will cause a constricting type of annular growth. Constricting type of annular growth. Okay? Why this is constricting type? Because they have a poor differentiating features. Either they have a huge amount of mucin within the stroma, or they produce stricture. Stricture means some fibrogenic material are produced by the malignant cell, and that is causing a thickening of stroma. This is known as desmoplastic change. The whole gross specimen will feel leather-like, hard. So this kind of growth is annular growth, circumferential growth, and this circumferential growth basically causes constriction of left side of the colon. And due to the constriction, any material inside cannot pass into anal canal. So if any material cannot pass here, that will cause distension. Inflammatory process may go on that produce an important surgical condition known as toxic megacolon. Okay, Hirschsprung disease. Why? This is another cause. Second point, if there is any obstruction, this obstructive area causing an fissure formation with external surface. Fistula formation with external surface. So along the obstruction there will be pathway formation, and that pathway ultimately opens up at the external epithelial surface. That is known as malignant fistula formation. So these 2-3 things are very specific for the left side of colonic growth. Other some non-specific clinical features. So the clinical feature might be, of course, there will be weight loss, dizziness, etc., etc. And it will cause iron deficiency anemia due to obstructive growth in the right side. If it is obstructive growth in the left side, that will present as occult bleeding. So in an occult bleeding, if I do the stool examination, occult blood will be positive for the stool, etc. And that will cause an inflammatory process also due to the obstruction itself, affecting the left side, causing the toxic metacolon, and an external fistula formation might go on, which is known as malignant fistula. These are mainly the clinical features. If it is an advanced stage like stomach carcinoma, This malignant cell may enter into the lymphatic circulation or hematogenous circulation. Hematogenous spread may go on, and it will cause a lymph node metastasis. So the lymph node may be paracolic, pericolic, or distal, superficial or deep, inguinal lymph node, etc., pelvic lymph node, obturator lymph node, etc., etc. And depending upon that, which group of lymph node affected, the staging will be different. The TNM staging will be different. বুঝতে পারলে কনসেপ্ট ক্লিয়ার হলো why this is mainly there are two types of colon cancer. That could be right sided colon cancer and that could be left sided colon cancer, which is histologically clinical with the clinical feature. They are totally different from each other. In right side, the precursor lesion is adenoma or adenomatous polyp, and this whole thing is known as classical pathway of adenoma carcinoma sequence. Why? There is a important initial mutation occurring in classical pathway of adenoma carcinoma sequence. This is an important theoretical aspect of histopathogenesis or pathogenesis of right-sided colonic cancer. কি হয় এতে? Initially, there will be 5q deletion affecting the APC gene. Okay. There are two alleles. One allele get deactivated due to that mutation. APC gene deletion mutation due to 5q APC gene deletion mutation. One allele gets deactivated, and a baby born with deleted 5q mutation of APC gene. This condition is known as first hit of pathogenesis of colon cancer. বুঝতে পারলে? দুটো অ্যালিল আছে 5q সাইটে ফোসাইয়ে। এই জিনটার নাম হচ্ছে এপিসি জিন, যার একটা সিঙ্গেল অ্যালিল ডিলিটেড হয়ে আছে এবং বেবি এই ডিলিটেড অ্যালিল নিয়ে জন্মেছে। দিস ইজ নোন অ্যাজ দ্য ফার্স্ট হিট অফ This is known as first hit. Okay. But in the later life, due to any reason, if the second allele of 5q again gets deleted, that will cause pathogenesis, initiation of pathogenesis of adenoma carcinoma sequence. This second kind of deletion is known as second hit. And there are two hits always needed for APC gene mutation related syndrome formation. It is known as Knudsen hypothesis. Exactly, this is tumor suppressing gene. কেন টিউমার সাপ্রেসিং জিন জানিস? বলতে পারবি? কে ভালো রবিন্স পড়েছে বলো? Exactly, APC beta catenin pathway initiator. If APC get mutated, the normal protective action of beta catenin just vanish. They are protective. Why? They inhibit the excessive proliferation or excessive turnover. সেখানে তো turnover সবসময় বেশি হচ্ছে, but excessive proliferation of epithelium is not there. Excessive proliferation of epithelium associated with the beta catenin mutation related to the APC gene mutation. So if the 5q deletion of two allele causing, this is the most initial mechanism, and after that mucosa causing, এটা নর্মাল মিউকোসাতে হয়েছিল, যখন সেকেন্ড ডিলিশন হলো, that mucosa converted into early dysplasia. Okay, early dysplasia. Second, in early dysplasia, there are even again some mutation. SMAD4 mutation. Okay, or KRAS mutation. If there is SMAD4 mutation and KRAS mutation in an early dysplastic mucosa, they go into an important initial precursor lesion which is known as adenomatous polyp. So adenomatous polyp is always associated with some kind of dysplasia, because already there are two type of lesion, 5q deletion, SMAD4 or KRAS mutation already occurring. Okay, and after the adenomatous polypoid structure gets mutated, the last hit will be p53 mutation. When there is p53 mutation, that will cause invasive adenocarcinoma. So initially there will be a normal mucosa, but within the normal mucosa, the second allele gets deleted in APC gene. It gets converted into the early dysplasia. There will be SMAD4 mutation or KRAS mutation. This early dysplastic change, this early dysplasia of mucosa gets converted into the adenomatous polyp. This adenomatous polyp, in the head of the adenomatous polyp, there will be P53 mutation. That will be the last mutation, and some other like telomerase activity increase, etc., some other adjacent mutation, adjunct mutation occurring on the top of adenomatous polyp, and that adenomatous polyp go into invasive colonic carcinoma. This whole sequence known as classical adenoma carcinoma sequence occurring in the right side. এটাই বোধহয় থিওরিতে পড়ানো হয়েছিল, কেউ শোনেনি, তাই তো? Next, but in the left side, the precursor lesion কি বলেছিলাম? sessile serrated adenoma or sickle serrated polyp. Right? Left sided colonic carcinoma is always associated with MSI, microsatellite instability syndrome. It is associated with two genes, MLH1, MSH2. These are DNA mismatch repair enzyme coding gene. So if there is any kind of mutation that will associated with microsatellite instability syndrome, MSI, microsatellite instability syndrome, and the normal mucosa in such cases converted into sessile serrated adenoma. On top of sessile serrated adenoma, there will be second hit in form of COX-2 inhibition or transforming growth factor receptor beta 2 gene mutation. COX2 gene mutation or transforming growth factor receptor 2 gene mutation. On top of secondary sessile saturated adenoma, there might be two kind of infection, and that sessile saturated adenoma again go into stage of invasive, of course, invasive adeno. See here হয়েছে দুটো সম্পূর্ণ distinct pathogenic pathway, one affecting right side, one affecting left side. One initial lesion is adenomatous polyp, another on the left side initial lesion is sessile serrated adenoma. One is associated with APC gene mutation, the first hit APC gene mutation, one associated with first hit microsatellite instability, MLH1, FSH2. One associated with obstructing polypoid growth, one associated with annular constricting growth. ব্যাস এই কনসেপ্টটুকু যেন থাকে, আমি আর কিচ্ছু চাই না, কেউ কিচ্ছু চায় না, তোমাদের আন্ডার গ্র্যাজুয়েটে আর কিছু বিশেষ চাওয়া হয় না, এই কনসেপ্টটুকু যেন থাকে। দুটো আলাদা জিনিস, সম্পূর্ণ আলাদা জিনিস সব দিক থেকে। ওকে, এবার আমাদের প্যাথোলজিস্টদের কিছু ফ্যান্সি জিনিসপত্র আছে। অ্যাডিনোকার্সিনোমাকে ইউজুয়ালি ডিফারেন্সিয়েটেড করা হয় দুটো তিনটে গ্রেডে, ওয়েল ডিফারেন্সিয়েটেড, moderately differentiated and poorly differentiated. Okay, দেখে নি চট করে। See, this is polypoid colony growth, polyp like invasive growth. There are so many areas having necrosis, ulceration of the overlying mucosa, raw blood vessels are opening up out, and the bleeding is occurring from the polypoid growth. Fine. Mainly this kind of features are usually present in the right side colony growth. Second, constricting annular type of growth, usually in the left side. দেখো এই জায়গাটা কি হচ্ছে, যেন পুরো লুমেনটাকে ন্যারো ডাউন করে দিয়েছে। আর well differentiated histological features কি তিনটে well differentiated, the glands will look like normal glands, malignant glands look like normal glands. Okay, these are small glands, they are lined by atypical epithelial cell. All atypical epithelial cell having features of dysplasia. So again, তোমাদের ইনিশিয়াল পিরিয়ডে একই কথা বারবার করে বলতে হয়, what are the features of dysplasia? High NC ratio, anisonucleosis, prominent nucleoli, loss of polarity, hyperchromasia, etc., atypical mitotic figure, etc., all. ঠিক আছে, গ্ল্যান্ডের অ্যারেঞ্জমেন্ট গুলো কি আছে? These are more or less round to cubriform, round to cubriform. দেখো এইগুলো দেখো, opening out roundish, or they are very smooth or irregular outline. Actually they are looking like glands, normal glands. Usually this type of features associated with very good prognosis, well differentiated. Cubriform, these are fused glands, cookie cutter appearance. These glands are having cookie cutter appearance. Within the glands, some eosinophilic material present. These are known as glandular secretion, any kind of glandular secretion. এই গ্ল্যান্ডগুলো দেখতে পাচ্ছ কত হাইপারক্রোমাটিক, লস অফ পোলারিটি হয়ে গিয়েছে, হ্যাঁ, নিউক্লিয়াস স্ট্র্যাটিফিকেশন হয়েছে, একটা সেলের মধ্যে অনেক কটা নিউক্লিয়াস পরপর করে বসেছে। দিস ইজ মডারেটলি ডিফারেন্সিয়েটেড, ঠিক আগেকার মতন নেই, কিছুটা সলিড স্ট্রাকচারও আছে। দ্যাট মডারেটলি ডিফারেন্সিয়েটেড অ্যাডিনোকার্সিনোমা যে ম্যালিগন্যান্ট সেলগুলো আছে, সেই ম্যালিগন্যান্ট সেল might produce some mucin also, and that mucin production is more than 50% of stromal content. This is known as mucinous carcinoma. কি বললাম? বলছি কি কি extravasation of mucin can produce any kind of appearance. কি বলা হবে? মিউসিন লেক। মিউসিন লেকের মধ্যে সেলগুলো ফ্লোট করবে, সেলগুলোও দেখতে কার মতন হবে? সিগনেট রিং এর মতন হবে। সো they are known as signet ring cell. This mucin are very tough and the gland will produce some tough structure of stroma. Okay, these are not due to the fibrous production, these are due to mucinous production. Okay, এটা কি জানো? এটা একটা ব্লাড ভেসেল। ব্লাড ভেসেলের মধ্যে ছোট ছোট গ্ল্যান্ড, ফিউজ গ্ল্যান্ড পড়ে আছে। উইদিন দ্য ব্লাড ভেসেলের মধ্যে ফিউজ গ্ল্যান্ড আছে। দিস ইজ লিম্ফয়েড, লিম্ফোভাস্কুলার স্প্রেড। লিম্ফোভাস্কুলার স্প্রেড যখনই তুমি কোনো একটা ম্যালিগনেন্সিতে দেখতে পারবে, দে আর an important prognostic factor, and if the LVI or lymphovascular spread is present, then it is a very bad prognosis. This is poorly differentiated. দেখো এই সেলগুলো দেখো, they are very visual looking, giant, অনেক সাইটোপ্লাজম আছে, নিউক্লিয়াস গুলো খুবই বাজে, নিউক্লিওলাই বোঝা যাচ্ছে, and they are present in few sheets, monolayer sheets, not forming glands. They are poorly differentiated adenocarcinoma. Okay, that's it. আর কিছু নেই। আর একটা দেখবে তোমরা মিউসিনাস, যার ক্লাস আছে, কোলোনি ক্যান্সার, এইটুকুই। দুটো প্রগনোস্টিক ফ্যাক্টর হয়, ডেপথ অফ ইনভেশন আর নাম্বার অফ লিম্ফ নোড ইনভলভমেন্ট। টু প্রগনোস্টিক ফ্যাক্টর, ডেপথ অফ ইনভেশন and number of lymph node involvement. And there are mainly two type of classification or staging. One হচ্ছে Duke and Clark staging, depending upon the depth of invasion, and TNM staging, tumor depth, number of lymph node and site of metastasis. That's it.